Good morning to all of you. Today I am going to talk about management of endophthalmitis in silicone oil field eye. So as we all know, silicone oil is used as the preferred tamponade in the complex via surgeries. But what we generally don't know is that it has antimicrobial and fungatic action against the common pathogens. So there was this gentleman, 81-year-old male patient, hypertensive, presented to us with diminution of vision in the left eye with visual acuity was 20/400. On examination, a massive submacular hemorrhage was seen in the left eye along with the cataract, and the right eye also showed a central scar. So we went ahead, did a combined surgery, and the pars plana vitrectomy along with subretinal RTPA was given in a multiple doses in the multiple sites. Along with that, anti-VEGF injections was given and silicone oil tamponade was done. On the day 5 post-op, media was clear, and we can see the submacular hemorrhages started to dehemoglobinize, and this was at the presentation, and the patient visual acuity improved to 636. But 2 weeks later, what happened? He presented with the increased redness, swelling, and diminution of vision in the left eye, and it is shown that there was corneal edema, hypopyon, along with discharge, and lid edema was there. And the posterior segment showed a media haze, and only the outline of optic nerve can be made. So diagnosis of acute endoph in silicone oil field was made. Now the dilemma was here, what should we do next? The options were either we go for oil removal along with intravitreal antibiotic and re-injection of silicone oil, or oil removal along with intravitreal antibiotics, or the intravitreal antibiotics alone. We did an anterior chamber tap as there was a hypopyon, and intravitreal injection of vancomycin and ceftazidime was given, and on the top of that the patient was started on the topical fortified antibiotics and with the oral 750 mg BD ciprofloxacin. The idea of using this was that the anterior segment infection will be taken care by the fortified eye drops, the perisilicone oil surface will be taken care by the intravitreal antibiotics, and the retrosilicone space will be taken care by the oral ciprofloxacin 750 mg BD. The rationale of using the 750 mg BD dose is that there is this article by Talwar et al. Who suggested that the therapeutic level of ciprofloxacin in retrosilicone space is achieved if we use BD dose of 750 mg ciprofloxacin. Meanwhile, the culture sensitivity came, and it was the coagulase negative Staphylococcus aureus, which is the normal commensal of the ocular surface and lid margin. In the follow-up, patient did show improvement with a clinical improvement, and by the 3rd week there was complete resolution of signs of inflammation with the improvement of visual acuity to the 20/100. And this is the clinical photograph, serial clinical photographs, which is showing wonderful media clear, hypopyon is gone, and at day 21 visual acuity was improved. So the silicone oil, the silicone oil field eye endophthalmitis is rare owing to the it has antimicrobial and fungatic action, and it also prevents the movement of microorganisms. So there are, in the literature, there are 2 groups. One group preferred the commonly preferred traditional method, the re-surgery, then intravitreal injection of antibiotic and re-injection of silicone oil. The other group preferred for the less invasive procedure, the Albushi et al. And the Steinman et al. Did this intravitreal antibiotic alone. So we also went ahead and we chose the comparative less invasive procedure for this patient, and we concluded that the minimal invasive treatment in the form of intravitreal antibiotic can also be used without any silicone oil exchange with proper follow-up and documentation for our clinical judgment. So my take home message for in this kind of patients, that endophthalmitis is rare, but timely intervention and prompt action is needed. We may consider a tap and injection of antibiotic with very close follow-up, especially if it's a better eye, it's the only eye, and the risk of re-surgery is much more than the benefit to the patient. So our goal should be a minimum intervention with a maximum gain. Thank you so much.
Thank you. So, what about cases like this was one case that you described? Have you also injected this in cases post retinal detachment surgery? And do you think that would help cause a failure of your surgery if you're injecting into the oil? Any such experience?
No, ma'am. This was the only patient where we actually have this end off in the silicone oil field. Other cases we did not encounter any end off. So we thought this was the something rare with the rareness of this disease.
So again, as was thought that silicone oil may not be a good medium for growth of bacteria, like you said,
Yes.
there was end off after, and I too over the years have seen quite a bit of cases with oil in situ and also getting endophthalmitis. So I think we need to revisit this idea that silicone oil inhibits the growth of bacteria. There have been no controlled studies, it's just a hypothesis, a proposition that was put forward. But I
Also,
think we
ma'am,
need to
in-
revisit
yes,
that idea
yes,
itself.
ma'am. And also that in this patient we did combined surgery. So there was cataract surgery was also done. That also adds up to the end of. It may be the factor for this end of in this patient also. So either we go for the alone VR surgery and combined surgery. There may be two different conclusions we will get.
Okay.
Yes.